We're now going to be moving on to the 6 indications for using hyaluronidase in clinical practice following dermal filler treatment. And the first of these is vascular occlusion. Vascular occlusion occurs when dermal filler is injected into the vessel, and this can be an artery or a vein. So it's important to keep your needle moving whilst you're doing injections. Now, if some dermal filler does get into an artery or vein, you can have different effects depending whether it's an artery or a vein. So a little tip is when you are injecting, always keep an eye on the adjacent skin, because if you do inadvertently inject into a vessel, you'll get blanching in another area where the filler can, move into the other area or reduce the blood flow. So you'll get blanching in the area covered. And that's a really good telltale sign to look out for. Now, importantly, if the filler's in the vessel, it can cause problems distally, so that's further down the vascular tree, but it can also cause issues proximally, and it does this by causing endothelial spasm. Endothelium is the lining of the blood vessels, and this can go into spasm from the hyaluronic acid filler. So generally, the consensus is when performing dermal filler injections, it's best to aspirate just to make sure you're not in a vessel. Now, you'll get quite different effects if you inject into an artery or a vein. Basically, arteries obviously take blood to the skin, veins bring them back. So if you inject into an artery, you're going to be reducing blood going to the skin. So you typically get a pale, cold appearance in the skin because there's no blood going to it. If you inject into a vein, you're obstructing the outflow of the blood from the skin, so the skin will become congested, so congested with blood. So arterial issue, generally pale and cold, not enough blood going in. Venous problem, there'll be too much blood in the area, so it will be sort of bluish. And a really good way of differentiating between the two is capillary refill. So when you press on normal area of skin, it will blanch, go white, and when you release it, the blood will come back into it in 1 to 2 seconds. If it's an arterial problem and there's not enough blood in the skin, when you press it, the capillary time, refill time will be longer. If it's a venous problem, there's too much blood in the skin, you'll press the skin, release it, and the colour will come back immediately because there's lots of blood in the skin. Vascular occlusion is estimated to occur in less than 1 in 100,000 cases. If you suspect a case, it is an emergency, you need to deal with it immediately, and you cannot leave the patient until it has been successfully resolved. The second major complication that you may need to use hyaluronidase is a scary one, and this is blindness. Now, we've never seen a case. I believe there is one case in the UK, and there have been several cases in Eastern countries, particularly in Korea, where more injections are used in the central part of the face. So how does it occur? Well, essentially, dermal filler is injected around the eye, and some of the dermal filler is carried to the main artery or vein supplying the eyeball. So dermal filler, or anything which is within blood vessels and moves within blood vessels, is called an embolus. So a little area of dermal filler can break off, travel in the blood, within the blood capillary network, to the back of the eye and block off the blood supply to the eye. And an embolus is the little bit that's moving around. Now, the eyeball needs to be free to move in the bony orbit. So it only has one blood vessel going in and one segment of veins going, which also travel with the optic nerve, which is the main nerve that takes vision back to the brain. So they all travel in a sort of a cord. Okay, now because there's only one way of blood getting in and one way of blood getting out, if that is blocked, there's a potential for blindness, and this is a serious medical emergency. So it's really, really important to understand this is really rare and you're unlikely to get the complication, but it's important to know how to recognise it and what to do. So the first thing, if you do have an issue with the eye, your patient will experience excruciating pain in the eye because the blood is blocked to the eye, and they also have difficulty seeing. So if you get any of those symptoms, you need to act fast. If you are experienced in this area, some practitioners recommend a retrobulbar injection of hyaluronidase. So this is an injection around the orbit itself, in the fatty tissue around the orbit, which dissolves the hyaluronic acid within the blood vessel. But I'd just like to emphasise this is not a treatment we would recommend unless you are extremely comfortable in giving injections around the eye itself. The retina is the area on the back of the orbit, back of the eyeball, which receives light, and this is very, very sensitive. Now, if blood supply is taken away from the retina, it will be irreversibly damaged within 60 to 90 minutes. So the blood circulation really needs to be restored within this time period. So if you do have any issues with the eye, and you're not comfortable doing the injections yourself, you really need to call an emergency ambulance and get them to the nearest eye unit as quickly as possible. So the third indication for using hyaluronidase is the Tyndall effect. And this is something we used to see more in the past with older fillers and less advanced injection techniques. But essentially it's caused by superficial placement of the dermal fillers, and then the light can react with the dermal fillers to make the skin look slightly bluish. So we can dissolve the hyaluronic acid fillers with hyaluronidase and resolve the Tyndall effect if indicated. The fourth indication for using hyaluronidase is an unacceptable immediate result following treatment. Now, we're really keen on training at Cosmetic Courses, and with our advanced courses, we really hope this wouldn't happen, but it can. So if you do a treatment and the filler is not in the right place, the patient isn't happy and you're not happy with it, you can dissolve the filler immediately. But again, this is not something we would really recommend, and with really good training, it shouldn't happen. The fifth indication for using hyaluronidase is delayed onset nodules, and we have seen a couple of these cases from our delegates. Now this typically occurs with nodules that appear months after the initial treatment. So initial treatment is absolutely fine, the patients are happy, but then several months after they develop nodules in the site of the injection. Now, no one is really quite sure why this happens. We know it does happen. It may be related to infections from other areas. So we should probably treat dermal fillers as implants, a bit like breast implants. So we know for breast implants you can get infections from other areas which tend to settle on the implants, and we think this is probably what happens with the dermal fillers. So it's basically an inflammatory response. So the body is recognising the dermal fillers as not native and mounting an inflammatory reaction. We generally manage these nodules, sometimes steroids, antibiotics, and by dissolving them with hyaluronidase. Delayed onset nodules are quite difficult to manage, but it's really important to try and work out the cause. So is it an infective cause? Is it an inflammatory cause? And clinically you may be able to differentiate these. A really useful marker we use is the CRP measurement. So the CRP is a blood test. Now if it's an infection, a bacterial infection, the CRP will be raised. If it's an inflammation, it will not be significantly raised. So that's a really good way of helping you work out whether it's an inflammatory cause or an infective cause. You're going to manage the nodules by a combination of possibly steroids, possibly antibiotics, but you can use hyaluronidase to dissolve the cause of the issue, to help dissolve the nodules. The sixth and final indication for the use of hyaluronidase is an immediate allergic reaction. Now this is really uncommon. We've never seen it, and the allergy could either be to the skin prep, to the lignocaine, or to the dermal filler itself. So if you do have an allergic reaction, if it's severe, you need to manage them with your emergency kit with adrenaline, but you can also manage them with steroids, and if indicated, removal of the hyaluronic acid if you think this is the cause of the allergic reaction with hyaluronidase. But I would like to emphasize, allergies to dermal fillers are extremely rare.